Good evening. My name is Von Seal Brown Miller. I'm with the Office of Community Outreach and Engagement with Karmanos Cancer Institute and Wayne State University. I'm happy for you all to join us for this important gathering of community and science. Yes, community and science can go together. The purpose of this series is to connect our community with our science and our science to our community. These conversations are a space to share knowledge, listen deeply, and build a strong connection between researchers, providers, and the people they serve. We are proud of our to be partnering with Detroit Public Library on our entire series. We thank them for their ongoing collaboration and support. We also want to recognize the community partners. Cancer Thrivers Network, Corktown Health, Healthier Black Elders, Michigan Ovarian Cancer Alliance, National Council of Negro Women, New Day Foundation, the Pink Fund, and We Run 313. And Western Wayne Family Health Center. We're also grateful for Global LT for providing translation services both in Arabic and Spanish. If you're joining online, you can select the language you prefer by clicking the interpretation option at the bottom of your Zoom screen. I have about 4 housekeeping tips for you. For our audience online, if you have questions during the presentation, please use the Q&A on the Zoom. For those attending in person, we kindly ask that you hold your questions until the end of the presentation. Please know we are recording this event to help share and expand the impact of our conversation. For those in person, restrooms are straight in the back and to your right. Finally, I would like to acknowledge and thank our speakers, Dr. Hadeel Assad and Dr. Michael Dominello, for joining us tonight. Both are oncologists with Karmanos Cancer Institute. We also have 3 moderators, Barbara LaRue, Anita Y. Orr, and Craig Cook. They will be guiding this important conversation. And I will now turn it over to our moderators to introduce themselves and get the program started. Thank you. Give my hand if you don't mind.
Hi, everybody. I'm Barb LaRue, and I'm president of the Cancer Thrivers Network. And I am a 21-year breast cancer thriver. Yay. The Cancer Thrivers Network for Jewish Women was founded in 2008 by Michelle Passon, Patty Niemer of blessed memory, and Sandy Schwartz of blessed memory. We welcome women who have experienced any type of cancer at any time in their life. In the words of our founder of blessed memory, Patty Niemer, we don't charge dues, we've already paid them. Our mission is to enrich and empower women through activities, friendship, resources, education, and humor. Because education is so important to us, we have partnered with Karmanos to bring these wonderful programs to the community, and I am honored to be here this evening to share this experience.
Good evening, everyone. My name is Anita Y. Orr, and I am a thriver volunteering with Karmanos Cancer Institute Center. I became involved through the Connor Creek Cancer Action Council more than 9 years ago. I became engaged as a caregiver and became a breast cancer patient. The training provided to me made my journey much easier. As an educator, I felt it is my responsibility to share pertinent and accurate information about breast cancer to my community. Welcome.
Good evening, guests. I'm Craig Cook, and a little history about my background and what brought me here today. My grandmother was diagnosed with breast cancer at Harper Hospital in 1974, which began my avid interest in cancer, and I began studying cancer at Wayne State as an undergrad. In the subsequent years, all four of my grandparents died. A very dear friend and my father passed away from cancer. At that time, I knew when I retired, I would join Karmanos and would dedicate the rest of my life to educating others on the need for early detection and reducing the number of cancer cases in the community. It's both an honor and a privilege to stand here today as a volunteer and advocate for Karmanos Cancer Institute, my dream job for the last 11 years, and look forward to many, many more. Thank you.
Now you better go to the podium. This
All right. Okay, everyone. Before we dive into today's topic, let's start with a few quick questions to see what we already know or what we think we know about this subject. Don't worry, this is not graded. It's just a way for us to reflect on our current understanding and get us thinking. This will help us connect what we are about. Oh, sorry. What we are about to learn with what we already understand. This is the pre-knowledge questions. For those of you joining us in person, you should have received a packet when you arrived. This is a white sheet of paper labeled pre-knowledge questions on top with 3 short questions. Please take a moment now to complete that sheet. Upon completion, please tear the sheet off and hand it to one of our COE members, team members, who will be coming around to collect them. For our participants joining via Zoom, a poll will be launching on your screen in just a moment with the same 3 questions. Pre-knowledge questions. 1. When and how often should a person with average breast cancer risk get a screening mammogram? Select only one answer. Starting at age 40 to age 75 years, once a year. Starting at age 30, every 5 years. Starting at age 50, every 2 to 3 years. And starting at age 25, every 6 months. 2. All breast cancers are treated the same. True or false? Or you're not sure. 3. What are some risk factors for developing breast cancer? Select only one answer. Physical inactivity, being obese or overweight, drinking alcohol, having family history of breast cancer, or all the above. Thank you for your participation.
mhm.
It's now my pleasure to give you some information about Dr. Hadeel Assad, who's going to be one of our keynote speakers this evening. Dr. Assad is a co-leader of the breast cancer multidisciplinary team here at the Barbara Ann Karmanos Institute. She's also an associate director of the Hematology Oncology Fellowship Program and associate professor in the Department of Oncology at Wayne State University School of Medicine. She is American Board Certified in Internal Medicine and Medical Oncology. Dr. Assad is a member of the Population Studies and Disparities Research Program at KCI and is a member of the American Society of Clinical Oncology, National Arab American Medical Association, and Michigan Society of Hematology Oncology. Dr. Assad is also involved in the Phase 1 clinical trials program at Karmanos, utilizing newly developed therapeutic agents, including cellular therapy for treatments of various types of solid malignancies. Her research interests include communication and disparities in breast cancer diagnosis and treatment, drug resistance, and new therapies in the management of breast cancer in the adjuvant and metastatic setting. As an expert in the oncologic management of breast cancer, Dr. Assad has authored numerous peer-reviewed publications and is currently principal investigator on several clinical trials at Karmanos. Dr. Assad's contribution to the field of oncology focus on cancer survivorship, medical decision-making, treatment side effects, and breast cancer awareness. And now, Anita. Whoop.
Yeah.
And it's my pleasure to introduce you to Dr. Michael Dominello. He is a professor of oncology at the Karmanos Cancer Institute. He is the medical director for quality for the Karmanos McLaren Network and is the medical director of radiosurgery. He is a member of the breast multidisciplinary team and is the team leader for the neuro-oncology multidisciplinary team. As you can see, he's a man of few words. But a lot of might. And the next person that you'll hear will be Dr. Assad, and she will present to you. She will make her presentation. And we are honored to have both of them here. And they're both participants in our new rap. And the word escapes me, but go ahead, Dr. Assad, I'm sorry. Oh, I'm sorry, research, it came back. Research advisors participant. And we have firsthand knowledge of the research that these doctors are doing.
Good evening, everyone, and thank you for joining us. And I want to thank the moderators for the wonderful introduction. I'm very happy to be here today to talk to you about breast cancer. You know, talking about breast cancer doesn't end here. We need to always talk about it and educate people about the importance of prevention and early detection. So what you'll learn from me today is who gets breast cancer and what are the symptoms, breast cancer screening recommendations, and when to consult with a doctor, and how breast cancer is treated. About me, as you heard from Ms. LaRue, I'm a medical oncologist, and what it means to be part of a multidisciplinary team is, in the cancer team, it's not just myself. There's a radiation oncologist like Dr. Dominello. There's also pathologists, there's surgeons, there's radiologists. We actually have a tumor board where we convene once a week and we discuss all of our new cases. So the recommendations that are delivered to the patient is a consensus from this whole team. And I happen to be a co-leader of that team with my colleague, Dr. Eric Brown. In 2025, it is estimated that over 300,000 women will be diagnosed with breast cancer, and 42,000 will succumb to this disease. The incidence of breast cancer actually increased sharply in the early 1980s after the rapid adoption of screening mammograms. And then it kind of plateaued and started to decrease in the early 2000s when we discovered that hormone replacement therapy that a lot of women were taking for menopause symptoms actually increased the risk of breast cancer. And so when women stopped using hormone replacement therapy, we actually did see a decline in breast cancer incidence. The good news is that the cancer death rate from breast cancer and other cancers, as you can see, is continuing to drop or go down. And that's because of early detection and better treatment and improvement in outcomes. 1 in 8 women will be diagnosed with breast cancer during their lifetime. That means that each woman has a 12% risk of developing breast cancer. There are certain risk factors that may increase someone's risk of breast cancer, and some of them are modifiable, which means that you can change them, and others are non-modifiable. We're going to start with discussing the non-modifiable risk factors. First is being a woman. All women are at risk. Age. Breast cancer is a cancer of aging. Actually, the average age of a woman to be diagnosed with breast cancer is 65. But we are seeing women even in their 30s and sometimes in their late 20s being diagnosed with breast cancer. Family and personal history. So if you have a family history of breast cancer, you're at slightly increased risk. And of course, if you have a personal history of breast cancer, you're at increased risk of another breast cancer as well. There are certain race and ethnicities that are associated with specific types of breast cancer. Radiation, so any radiation exposure to the chest wall that is, of course, not due to treatment for breast cancer, but the most common cause is treatment of lymphoma in the adolescent or early adulthood, which involves radiation to the anterior part of the chest. And so the breasts do get exposed. Women who've had radiation for lymphoma are 4 times increased risk of developing breast cancer during their lifetime. So they have to have increased or high risk screening. Certain genetic factors, actually 10% of breast cancer is hereditary, meaning that there are certain genes that can be passed down that increase the risk of breast cancer. We'll talk a little bit more about that. Menstrual history, so early periods, having a period early and also late menopause increase the risk. And then no pregnancies or late pregnancies are slightly associated with increased risk. Now, what are the modifiable risk factors? We have obesity or being overweight increases the risk of breast cancer. Lack of exercise and not breastfeeding also is associated with increased risk. Any alcohol intake is also associated with increased risk. Hormone replacement therapy, like we discussed, which is medicines, estrogen, progesterone replacement used to treat menopause symptoms. And then certain birth controls also that have dual estrogen, progesterone are associated with increased risk. But that's, it's a small increased risk and it actually does decrease after discontinuation. So all cancer is genetic, but it's not hereditary. What that means is cancer develops as a mutation or a change in the gene that develops these ability to become immortal. And how cancer affects us is its ability to go to other organs and result in organ failure. And so that's how cancer develops. Now, hereditary cancer means that we have 2 copies of each gene, and inheriting one abnormal or altered gene from either your mom or dad can sometimes increase your risk of breast cancer, essentially because it means that you only have to develop or acquire one additional mutation in that second gene to develop cancer. Whereas if you don't have that mutation or alteration in all your genes, you need 2 hits or 2 mutations in order for cancer to develop. So that's the difference between hereditary and non-hereditary cancer. But only 10% of breast cancer is actually hereditary, which means can be passed down from generation to generation. There's about 15 to 20% that are familial, which just means that we see some clustering in families, but there's no genetic mutation identified. And that could be due to environmental factors. And sometimes it could be due to genes that we just haven't discovered yet. But majority of breast cancer is not hereditary. The most common hereditary mutation is the BRCA mutation, the BRCA1 and 2. And if you've all heard of Angelina Jolie, she actually had that mutation. She opted for preventative bilateral mastectomy to prevent developing breast cancer in the future. But their risk, so if someone carries a BRCA mutation, the risk of getting breast cancer during their lifetime is up to 80%. That's 8 times higher than the general population. There's also an increased risk of other cancers such as ovarian cancer. So what are the signs and symptoms of breast cancer? Painless lump is the most common symptom of breast cancer. However, it can sometimes be painful, so it's not always painless. Any sort of nipple discharge, especially if it's bloody, can be a symptom. Any changes in the nipple contour or retraction can also be a symptom. And sometimes you have changes or crusting in the nipple or changes in the breast-like redness or orange peel appearance. How do we diagnose breast cancer? First, we get imaging. Typically, that's a mammogram. And it's not a screening mammogram if someone has symptoms. It's a diagnostic mammogram, which actually involves two views, whereas a screening mammogram is done when you have no symptoms, and that is typically one view. Sometimes we use ultrasound to help identify abnormality, and then a biopsy is done. A biopsy is essentially when a needle is stuck in the area that's abnormal or the lesion, and a sample is taken and sent to the pathologist. The pathologist then looks at it under the microscope and tells us if it's cancer or not. So all breast cancer is treated the same with surgery, radiation, or chemotherapy. This was one of our questions, and the answer to this is false. There's actually 3 or 4 different types of breast cancer, and they have different outcomes, and they are treated differently. When you think about breast cancer management, you can think about managing early stage disease, which is stages 1, 2, and 3, or stage 4, which is metastatic. For early stage disease, the treatment typically involves multimodality, surgery, radiation, and systemic therapy, and is with curative intent. The treatment for stage 4 disease, when the cancer is beyond the breast and regional nodes, is typically systemic therapy, and which is anything you take IV or orally that will go everywhere and treat all the spots. And the goal of treatment is palliative. We continue to improve breast cancer outcomes and survival. And in fact, we can cure more than 70% of breast cancer. And the survival outcomes continue to improve with our current clinical trials. When thinking about treatment for early stage disease, we think about surgery that can either be lumpectomy, removing just the lump, or mastectomy, which is removing the whole breast. We actually like to preserve the breast when possible because the outcomes are the same if we involve radiation. So lumpectomy plus radiation is equal to total mastectomy in terms of survival and outcomes. Now, where the medical oncologist comes into play is trying to estimate the risk of micrometastasis. What is the chance that this cancer will give us a problem in the future? And we use the biology of the cancer and other characteristics to estimate that risk. In surgery, it's also important to identify margins or obtain, negative margins. Margin means the border, the normal tissue border around the cancer specimen. And we like there to be no cancer in the margin because we worry if there is cancer in the margin when, after surgery, that there's some cancer that might be left behind. And so sometimes a second surgery is needed. We talked about systemic therapy. The goal is to prevent the cancer from recurrence. So systemic therapy is anything you take orally or IV that goes everywhere and prevents cancer from returning. It can be chemotherapy. It can also be hormonal therapy, which is the most important if you have hormone receptor positive breast cancer. There's also HER2-directed therapy and other targeted therapies as well. Just to quickly touch on metastatic breast cancer treatment, we discussed that this is when cancer cells have escaped the breast and the regional nodes and can involve essentially any part of the body, but the most common area is bone. The mainstay of treatment is systemic therapy. We use radiation and surgery as needed to treat problem areas. And we call the treatments lines of therapy. We go from one line or one regimen to the next based on how the patient responds and how they tolerate it. And we keep going with the treatment as long as the patient's responding and tolerating it. It's very important to ask about clinical trials. And we did not get to where we are today in terms of improvement in outcomes without clinical trials. We are constantly looking at ways to escalate therapy when needed to improve outcomes or de-escalate therapy to prevent, toxicity from additional therapy if it's not needed. So it's very important. Precision medicine basically means when you are targeting the mutation in the cancer, and we are always, always doing precision medicine when we are thinking about cancer treatment. Finally, with prevention, it's important to obtain and maintain a healthy weight. So any BMI of 18.5 to 25. that actually prevents or decreases the risk of developing breast cancer and other cancers. Low fat, low carb diet also reduces the risk of breast cancer recurrence. Staying physically active. So the American Cancer Society recommends about 150 minutes of physical activity per week. And house cleaning is not physical activity. You need to have your heart rate at a certain level. And so avoiding or limiting alcohol, knowing your family history, and primary prevention. Sometimes we actually use tamoxifen in someone who never had breast cancer to prevent or decrease the risk of breast cancer. Screening mammogram, it's important to get your screening mammogram for average risk population once a year, starting age 40 up to age 75. This is for average risk. We said that some women are higher risk. They might require MRI. They might require screening at an earlier age. And there are screening programs like the BCCCP for those who are uninsured or underinsured. So in summary, all cancers are genetic, but only 10% are hereditary. There are certain gene mutations that can increase your lifetime risk of breast cancer. Most common is the BRCA mutation. Very important to know your family history. Ask your family about their cancer history, how old they were when they had it, whether or not they had genetic testing, because that can affect your screening recommendations and whether or not you should get genetic testing. We talked about screening once a year starting age 40 for average risk. Consider additional testing if you have dense breasts or increased risk of breast cancer, and then work up breast symptoms. Even if you had a normal mammogram, a normal screening mammogram a few months ago, but you have a new symptom that developed, you should get the appropriate workup. And these are some good resources to refer to. Thank you.
Get a lecture and learn something else.
We're going to have a 30-second pause.
Interpreters online, please go ahead and switch now. Thank you.
All right, I'm getting a thumbs up. So, what a great talk. I don't know how you fit all of that in 15 minutes, but that was incredible. So one more big round of applause for Dr. Assad. As Dr. Assad mentioned, we work in these things called multidisciplinary teams. So Dr. Assad is the team leader for the breast team. And the three professions or the three tools that she kind of touched on, the oldest one is surgery. You cut it out. Radiation came along in the late 1800s, early 1900s. So radiotherapy, and then medical oncology, like Dr. Assad, and typically they're managing what we call systemic therapy because it goes through your system, and that can be hormones or it can be chemotherapy. But a little something about Dr. Assad, I feel very lucky because when we share patients, it's like, okay, I'm reading the notes from this patient or that, or this physician or that physician, but I'm always very happy when I see that Dr. Assad's taking care of one of my patients also, and I say she's fantastic. You're in great hands. So I feel very lucky that we have such a great team. A little bit about me. So I'm a transplant. So I'm from Connecticut. I'm from Meriden, Connecticut, and I went to medical school in Maine. I had to buy a new winter coat for that one, but it turned out to still be pretty good in Detroit.
Yeah.
So I don't know how many people out there might or might not know this, but when you are a medical student, you don't exactly get to choose where you go for your residency training. You enter your requests, we'll say, into a computer system, and then the computer spits out an answer that tries to maximize happiness for everyone. So I was pretty surprised when this Connecticut boy heard he was going to Detroit for training. So I got to train for 4 years at Wayne State. Boy, did I fall in love with the city. And that doesn't, I mean, the buildings are great, the architecture is incredible, the food's incredible, but I'm talking about the people, and that means all of you. So thank you for welcoming me to your city.
You're welcome.
And the purpose of my talk is kind of going to be to act as a springboard so that we can kind of get into a little bit of Q&A and discussion afterwards. But the take-home point is that not all radiotherapy is created equal, okay? So some major questions that we're going to touch on is who gets radiotherapy? We're talking about in the setting of breast cancer, of course. How is it delivered and why? And then what are the expected side effects and how do we mitigate them? So how do we know this side effect is coming, how do we try to prevent it, or how do we decrease the likelihood of that side effect? And so stealing a slide from Dr. Assad, at least in part, and adding my own little touch there, which will quickly substitute with this guy. We're talking about our breast cancer patients, stage 1, 2, 3, in my talk, and these patients have undergone typically the surgery already, and they may or may not be getting chemotherapy, and they are possibly getting radiation. So we're talking about these patients right here, stage 1, 2, and 3. And this illustration, this shows the difference between a lumpectomy and a mastectomy, and it's not projecting that well, and the laser pointer is not showing on this, but here you can maybe see that the woman has this very small incision. The tumor has just been removed, and the surgeon has left the rest of the breast intact. Okay, whereas for this patient, either because she elected to have a mastectomy, or more often than not, the tumor was too large such that it made sense you couldn't save the breast. If the whole breast is involved with tumor, or a large portion of the breast is involved with tumor, or there's multiple tumors in the breast, someone may need to go for a mastectomy. And so when we go back to the lumpectomy patients, the tumor itself is removed. To reiterate what Dr. Assad said, because repetition is educational, these patients typically will get some radiotherapy after their lumpectomy. And that can be 1 week, that can be 4 weeks, that can be 6 weeks, okay? And that will depend on a few things. A patient who has a mastectomy, if they had a teeny tiny tumor, but they chose to have a mastectomy for one reason or another, then they may not need radiotherapy. And those outcomes are the same. Lumpectomy plus radiation versus mastectomy for early stage breast cancer, equivalent survival outcomes. But as I alluded to, more often than not, what we see is someone is getting a mastectomy because there's too much tumor for them to necessarily save the breast. And these patients will also receive radiotherapy. So what are our priorities as radiation oncologists? So we focus on treatment-related side effects and taking every step to minimize them. And we think about early and late side effects. Early side effects are things that happen during the course of radiation treatment, whereas late side effects are things that patients can experience months or even years later. Our goals, what this means is we are trying to, in the long run, decrease the amount of radiation that the heart sees. We aim to get that dose as close to zero as possible. And we try to decrease the skin reaction, particularly for lumpectomy patients. Patients who have had a mastectomy, most commonly, if they recur, if it comes back on the surgical scar. And so patients who have had a mastectomy are likely to have more of a radiation skin reaction because we're intending to treat the skin. It's part of our target. Whereas someone who's had a lumpectomy, we're trying to treat what's inside the breast. And so this is about the worst of it in usual cases for a lumpectomy. Like I said, mastectomy skin reactions from radiation can be more severe, but this is probably in the last week of treatment. And what you can see here, this is where the patient had her surgery, and you can see what we call a little bit of moist desquamation. We also call it skin peeling. Some people call it a radiation burn. I've heard that also, but lumpectomy patients will usually have a very mild reaction. Again, this is kind of the worst of how we allow it to get. And this is typically treated with topical creams and non-steroidal anti-inflammatory drugs. So that's things like ibuprofen or Motrin. And thank goodness skin heals very, very quickly. Okay. So just like mouth sores heal quickly, skin irritation heals quickly. So if anyone's ever had a sunburn, it takes about that same amount of time to heal. And so usually within a week, people are feeling better. By 2 weeks, people are feeling much, much better. Let's talk about the heart. So this is a paper published in the New England Journal of Medicine. This is one of our most reputable journals across all specialties in medicine, not just oncology. And these folks actually modeled a risk of heart disease, likelihood of having a heart attack for women who received breast radiotherapy, left-sided breast radiotherapy, back when we didn't know how important this was, okay? And so in this study, patients had pretty high doses to the heart, much higher than we would ever accept today. The average was about 5 gray. And that doesn't mean much anything to anyone here, but I would say that that's our units of radiation, and I would say that's a very high dose, okay? And what this shows is basically, depending on your risk factors and depending on the amount of radiation that the heart saw, your risk increased quite a bit. And so when we actually quantify that, the increase in risk was about 7.5% for every 1 gray difference. So when you think about that, that's big time. So they're saying the average was 5 gray and 7.5%. That's more than 35% relative increased risk. So this really opened a lot of people's eyes. We certainly knew by this point radiation was no good for the heart, but this group actually quantified it and published it in the New England Journal and helped us to really kind of modify our priorities. So how do we do that? So there's a few ways that we do that. One of the best ways we do this is with a technique called deep inspiration breath hold. And what that means is when the patient is lying on the table, this is when we're treating someone lying on their back, and we'll get into that in a moment, in my remaining 4 minutes. We will prompt them to take a deep breath in. All right, Ms. Jones, take a deep breath in and hold it. And so she holds her breath for 20 seconds. And what happens is the lung fills with air. It pushes the heart, scoots it back out of the way. And then we're able to deliver the radiotherapy to the breast. A little sliver of lung sometimes sees the radiation, but the heart is usually well out of the field. And so that's a trick that we use these days to do this. The acronym we use is DIBH. Another of my favorite ways of avoiding dose to the heart when we can do it is something called prone treatment. Now, this is not terribly comfortable for all patients, but many actually prefer it to lying on the back. And this allows us to use gravity to pull that breast away from the heart and the lung. And this is what that setup looks like on a CT scan. Okay, the black is the lungs. This is the heart right here. This is the left breast hanging down. And you can see the dose is kind of just missing the heart. And so this is another technique we can use to kind of get the breast away from the heart. Lastly, we've investigated some new techniques using our fancy machines that we're fortunate enough to have at Karmanos. This is a technique that we actually developed and published on a couple years ago called tangential volumetric modulated arc therapy. So we call it tangential VMAT for short. And what we were able to show was actually with as I mentioned, in the New England Journal paper, the average heart dose was around 5. Our average heart dose before we started doing this was about 2. So much, much, much better. And using this technique, we were able to get it down closer to 1.6. We've really worked on this quite a bit, and I would say our average right now is well under 1 gray. So we keep it as close to 0 as possible. And so with that, I want to thank all of you for being here. I think this is wonderful, and I'm so glad I was asked to participate in this.
Right. You can answer from here, can't you? You can sit. You can sit, or you can sit. Mhm.
Okay, I can do it sitting down. Okay. Okay, so now we're going to open the floor for Q&A with our guest speakers. And we ask, please keep your questions general and refrain from asking about specific personal medical cases or patient experiences. This helps ensure the conversation stays relevant and helpful for the entire audience. If you do have questions about your individual situation, Dr. Assad and Dr. Dominello, who are part of Karmanos Cancer Institute's breast cancer multidisciplinary team, they would be happy to see you at a future appointment. And patients can be seen at Karmanos for a second opinion appointment within 7 days of their initial contact. So please do not hesitate to follow up with them directly. Okay, so with that said, let's open it up for your general questions.
Question? Gonna step in the back.
Thank you. Thank you, both Dr. Assad and thank you, Dr. Assad. And I'm sorry, I don't remember the radiologist's name, but thank you all for your information. My question is for the radiation oncologist, and I was wondering, how do you make certain that other body parts aren't affected by the radiation if the person has mobility issues? If they can't move one body part away from where the radiation needs to be.
Thank you for your question. That is something that comes up probably not less than once every 2 months, I would say. The most common situation we run into, you might have seen in some of the pictures I had, the most common position, whether someone's lying on, can you all hear me? Is that okay?
Yeah.
Whether they're lying on their back for treatment or prone on their belly. Usually we're trying to get the arm on the side of the breast that we're treating up and out of the way. And that can be a difficult time for people, particularly stroke patients. And so for our stroke patients that we take care of, we use a special board and setup to actually help navigate their hand down by their side and out of the way. We use specialized beam angles to still treat the breast while staying away from everything else. We at the same time, regardless of someone's mobility status, kind of the most important things to also keep in mind are keeping the other breast out of the radiation field, the lung, and then, as I mentioned in the presentation, the heart. But I would say that we definitely have many people we treat with mobility issues, and we're able to do this with a team approach.
I had a question. I wanted to know if a person is having radiotherapy, is it every day for so many weeks?
Yeah.
So most commonly for breast cancer, yes, it is given every day. For the very lowest risk patients who have a surgery where there's lots of normal breast tissue removed around the tumor. So we call that the margin. So they have very good margins, clear margins, and they have low risk cancer, and they're older than, we'll say, 65. We're able now to actually do this with 5 treatments, 5 consecutive treatments. But I would say that for the average risk patient, it's every day, Monday through Friday, with the weekends off for 4 weeks. And for patients who have cancer that's spread to the lymph nodes, we're typically doing it every day, Monday through Friday, for usually six weeks. So it all depends on the risk.
Hi, and my question is regarding the hormones. You say it's in your presentation. It said that hormone treatment was a factor, could raise the chances of you getting cancer. Did they ever find out why hormone therapy had an impact on your chances of getting cancer? Then my second question is that I didn't see a diagram breaking down breast cancer in races. And that's a concern for me because in the research that I've done and in the communities that we come from, we see that Black women are having the higher rates of breast cancer.
Thank you for those questions. Those are very important questions. So to answer the first question, hormone replacement therapy is different than hormone therapy for breast cancer, which is actually anti-estrogen or anti-hormone therapy. They both have the same word, but one of it is actually estrogen and progesterone replacement. So when the ovaries stop producing estrogen and progesterone, and we call that menopause, sometimes there's a lot, women can experience a lot of menopausal symptoms like hot flashes and, and things like that. And so essentially, you're taking a hormone, an exogenous external hormone, to replace what the ovaries stopped producing. Okay. And that usually helps with treating these hot flashes and menopause symptoms. What we found was actually when you get exposed to long periods of time of external estrogen and progesterone, your breasts have sometimes changes and there's an increased risk of developing breast cancer. And so that's what we discovered with the Women Health Initiative, which is a very large research that showed that women who took hormone replacement therapy had an increased risk of breast cancer compared to those that did not. And so, that's the evidence behind hormone replacement. Now, when we talk about hormone therapy for breast cancer, that's actually anti-estrogen or anti-hormone. So essentially, it's a hormone blocker. It does the opposite. Okay. And there's several of those. Some of them we call aromatase inhibitors, which act on actually a enzyme in the fat cells that converts steroids into estrogen. And so it blocks that. We use that frequently in postmenopausal women. It's called anastrozole or letrozole. And then the other one is tamoxifen. Tamoxifen is a selective estrogen receptor modulator. And what that means is it works as an estrogen receptor blocker in the breast and an estrogen receptor activator in other areas like the bone and the uterus. So those are treatments that decrease risk of breast cancer recurrence. And sometimes we actually use them to shrink the cancer as well before, for example, surgery, or if surgery is not an option. To answer the second question about race and ethnicity and specific types of breast cancer, you are absolutely right. There's a lot of data and a lot of work being done looking at differences between types of breast cancer and incidence of breast cancer. And, what we found was that Caucasians have increased or higher risk of breast cancer compared to Black population. However, Black population have increased risk of triple negative breast cancer, which tends to have more aggressive course and, worse outcomes stage by stage. And, we don't always know why that is the case. There is some data suggesting that there's some sort of differences in genes or, genomic kind of makeup or ancestry and things like that that can be contributing to that difference, but we don't always really know why.
Young lady.
Hi, how are you? I have a two-part question. The first question is, can certain asthma inhalers cause breast cancer? Because they affect your lungs and your heart. And, I'm just asking because your breasts are in that area.
I've just conferred with Dr. Assad, and we both agree as far as we know, none of the FDA approved asthma medications increase the risk of breast cancer as far as we know.
And then my second question is, can living in a toxic environment, such as Southwest Eterna Del Rey, cause breast cancer? Air pollution specifically.
I don't personally know the answer to that. I'm not aware of what the limitations of the data that are out there are. Are you aware, Dr. Assad?
So, in general, smoking increases the risk of
No,
all
no question.
cancers, not just breast cancer. That's why I really encourage my patients who smoke to quit cigarette smoking, because that actually can increase the risk of recurrence of breast cancer if we're trying to cure them of the cancer. So in the same way, sometimes pollution can be carcinogenic. Carcinogenic means cancer causing or cancer inducing. Essentially, it can change some, genes or mutations can develop in certain genes. And, it just takes one cell to develop these changes or mutations in the gene that develops into, basically makes it immortal. And that's how cancer develops. So it's certainly, there are some environmental factors that can increase the risk. I don't know that we really know exactly what they are. And there's more direct relationship between environmental factors and smoking and lung cancer, but it also increases risk of all cancers too.
We have time for what? One more question?
Okay,
No, we don't.
No, no questions online.
okay. You answered one of my questions was in reference to smoking because I didn't see it on the presentation. But my other question is the BMI factor, body mass index. Okay, now I would imagine it's the person's diet while they're over that 40. Well, no, you said 18, 18.5,
Yeah, to 25.
18.25.
Which is normal.
So I do. I'm not gonna say I have some issues with that, but anyway, I have been trying to use non-oil, which was recommended to use the spray the oil under pressure in the can, but you have to be specific about what you're purchasing because some of them had artificial preservatives or whatever in them. But I would think using natural oils, olive oil, whatever, not for frying, because I'm not deep frying, but just to put in your food or just to saute something would be better and healthier than purchasing those oils in the can. So diet is an important issue as well. Is that correct in regard to what we're eating?
Yeah, I think it's very important to maintain a healthy diet. And I'm sure, there are healthier versions of oil than other types of oil. And also, in general, not frying food and grilling it is healthier and so forth. So, there's no strict diet recommendations for someone to prevent cancer, even someone with cancer to prevent a recurrence. I get asked that a lot of times. What should I eat? Should I stop eating sugar? Things like that. And what I usually say to the sugar question is sugar has no nutritional value. So, avoiding or limiting it is a good idea, but you don't have to completely cut it out. It's not like if you eat a little bit of sugar, your cancer is going to come back or, you're going to increase your risk. So I think, things in moderation and just trying to eat healthier in general is always a good idea.
Okay. I love that. I love that answer. Very much. Muncie? Okay.
They're gonna let us do one more.
Yep.
You have a question?
Yes, I just wanted to know, is calcification in the breast a form of cancer?
No. That's actually a very good question. It is not a form of cancer. It's how radiologists describe changes in the mammogram. There are some calcifications that look normal and some groups of calcifications that look abnormal. And, I must give it up to our radiologists because they look at these and they tell us if this group of calcifications warrants a biopsy or something that we just monitor or if it's benign. And I mean, it takes a lot of experience for them to be good at reading it, but it's not, that you have calcifications means that you have cancer, increases risk of cancer.
Thank you.
Wow, that's a good question, wasn't it?
Now Craig is gonna.
I thank you all. We're gonna close our questions up for now. Our docs are gonna stick around so you can ask them your individual question at the end of the program. That's not me. Huh. Okay. So before we get started, we have one more thing that we need to do with you all. We need to do your post questions. Okay, so
Okay, can we take a moment to reflect on what we have learned? We just have a few quick questions to help us think about the key takeaways from today's session. For those of you joining us in person, please take a moment now to complete the highlighter yellow colored sheet of paper labeled post-knowledge questions. One of our COE team members who will be coming around to collect them. For our participants joining via Zoom, a poll will be launching on your screen in just a moment with the same 3 questions. Please take a minute to answer them using your device. But we're going to cover the questions, okay? On the back also. We only covered 3 at the beginning, but there are questions on the back too. And it's not a time test, but we do want you to finish it and turn it in before you leave. When and how often should a woman with average breast cancer risk get a screening mammogram? All right, is that a consensus? The first one, starting at age 40 to age 75 years, once a year. Number 2, all breast cancers are treated the same. False, very good. What are some risk factors for developing breast cancer? Select only one answer. All of the above. Very good, very good. See, docs, we've learned.
Goodness.
Okay, radiotherapy for the treatment of breast cancer is given over how many days? All right, depending, any of the above, depending on the details of the breast cancer diagnosis and type of surgery a patient has had. The expected amount of skin irritation when treating a breast cancer patient who has had a lumpectomy is the same as the expected amount of skin irritation for a patient who has undergone a mastectomy. False. Okay. Did I hear somebody disagree? Okay. Okay, which of the following is a technique your doctor can use to minimize radiation dose to the heart? All right, very good, very good.
we're gonna pick those.
Thank you for your participation. And please complete the evaluation included in the packet that was found on your chair.
So I have another evaluation on your chair, and if you would take a moment, and that is going to give us feedback about how we did with the program today. So please take a moment and fill that out, and between Zach or Addison, they'll pick them up.
That's yours.
Yes.
Mine was similar, so I.
Same dot? No, different. Mhm.
Oh, yeah. Oh, yeah.
All right, well, it's
Sure.
your turn, so,
No, thank you.
no questions.
Yeah.
Okay.
My patience. It's love, it's nice, just, you know, I don't know. Don't have to worry about. You don't have to worry about.
Okay. So I really want to thank you all for coming out tonight, both in person and online, to participate in this important conversation. And I'm sure you will want to share this information with someone you know and love, where it'll just help you retain it. Thank you to our oncologist, Dr. Hadeel Assad. Give her a little hand, yes. And Dr. Michael Dominello, and as well, for sharing their time and expertise and cutting edge knowledge with us this evening. We also would like to thank our moderators. They did a great job, didn't they? Yes, they did. Barbara LaRue, Anita Y. Orr, and Craig Cook. They are community leaders. We also would like to recognize the Detroit Public Library main branch. I love this library. It's so beautiful. And if you look around, just look, we have art. It's just amazing what's going on right around us. So We thank the staff here, Adrian and Brian. We're gonna give you a little shout out. Woo. Thank you. We want to also thank our partners, Global LT, for making this space accessible through Arabic and Spanish interpretation. Yes, absolutely. You want to be able to understand what's going on. Our next event is November 5th. The subject, how to communicate with your doctor to get the information and support you need. Do we not need this information?
Yes.
Yes, I hope you all will be here on November 5th. Our speaker will be Dr. Lauren Hamill. Please stick around for a few minutes. We have food still in the back. We have our vendors here. And our doctors are going to stick around so that they can entertain your questions. And from all of us, from the Office of Community Outreach and Engagement, we thank you, and please do have a good night and safe driving, safe travels. We still have evaluations that need to be picked up. So just raise your hand if you have an evaluation. Thank you so much. And special thanks to Teresa. She is a warrior. I love her. Okay. Great job.
Ta-da.